actually usually belts around the body over the chest or the abdomen, and basically looking at people's muscle movements and muscle contractions. And what you see is that even when there's no air movement, people are actually trying to move air, but they're just having blockage of breathing, which is what obstructive sleep apnea is. And at the bottom, you see the oximetry showing that there's these repeated oxygen desaturations that occur that basically are part of the reason we treat sleep apnea, part of the reason that we will see these health-related consequences. And sometimes even the desaturations get a little bit more pronounced as we get past the point where people start breathing, just because there's a natural delay between breathing in and getting oxygen to your body. So this is what obstructive sleep apnea actually looks like. And certainly we see it, in the post-operative setting for any kind of patient that can have it just physically. They're trying to breathe and they can almost be moving their whole body, but not getting any airflow in and out. So I've told you already, there's quite a common issue. And here's a study that's pretty old, but it showed that quite a high rate of underdiagnosis. And I think these numbers are roughly about half the patients are currently underdiagnosed, according to this organization of patient advocates and some physicians and other providers that are involved in the American Sleep Apnea Association. So what are the risk factors? How might you identify some of these patients? And Grace mentioned the Stop Bang questionnaire, and certainly one of the studies she mentioned alluded to this, which is one of the preoperative questionnaires that can look at things like snoring, basically high blood pressure, body mass index, some of these things that are risk factors for sleep apnea. But here I've listed some of the ones that we commonly see. So men, especially compared to women before menopause, men are more likely to have obstructive sleep apnea. Age is a common risk factor. Sleep apnea is more common actually among children. It's the #1 reason that children get their tonsils and adenoids removed, or at least tonsils removed. It's actually very common in older adults. So over the age of 60, it's actually 40% of patients will have some degree of obstructive sleep apnea. Not that all of them need to be treated, but they will actually have this. So it's very common. I know you see this all very commonly. Basically gaining weight, whether you're overweight or in the obese range, according to your body mass index, that's definitely a risk factor for obstructive sleep apnea. And probably it's not necessarily all body weight is not created equally, meaning that the head and neck body weight, some people store a lot more body weight in their head and neck area. And one of the ways we have of gauging this is the neck circumference. Women don't always know this, but if you want to know the numbers that are used as a criteria for risk factors, a 16-inch neck circumference for women, and in men who, just because of, well, we used to be going to the office wearing button-down shirts. Men used to be very familiar with their neck circumference, but that's the cutoff for men. But there are also other structural abnormalities, whether it's large tonsils or adenoids, certainly very important in children. And then in adults of all shapes and sizes, having a small lower jaw or mandible is a huge risk factor for obstructive sleep apnea. And then in some people, whether it's due to just being muscular or storing their body weight in that head and neck area, they can actually physically have an enlarged tongue, which plays a role. And the reason why this happens is because as you breathe in at nighttime, you want airflow to come through your nose here and then go through your throat and into your lungs through your trachea. And there are different areas where breathing passages can be blocked. One is up high in the throat behind the soft palate, but can also occur down lower in the throat behind the tongue, shown right here. I mentioned before, and we're all familiar with it, snoring is a big clue that someone may have some obstructive sleep apnea, although there are many people with sleep apnea who do not snore at all. And then some of the consequences, sometimes people are just so sleepy, they talk about even though they sleep as much as you could possibly imagine, they're waking up still feeling very tired or fatigued. So Grace alluded to these different treatment options out there, and this is what goes into not only the post-operative, but really the preoperative discussions, at least in patients who are diagnosed. And so these are the 4 categories of treatments. The first and foremost are the most conservative options of behavioral measures, including weight loss. Very important, very helpful, often very difficult for these patients because they're so tired. They say, I'm going to start being more active, not to mention, of course, the COVID pandemic, but how am I possibly going to be more active to try to burn off some calories because I'm just so exhausted? It turns out that sleep deprivation of any kind can actually increase your appetite. Interestingly, perhaps more for carbohydrates than anything else. But anyway, it's something that weight loss can be very challenging, but it's certainly something we use in patients who are overweight or in the obese range. Grace alluded to body position, and certainly in the preoperative area, it's very common to have to recommend avoiding the supine body position or avoid sleeping on your back, because about 50% of patients have what we call obstructive sleep apnea. So they'll have at least a major improvement, maybe not clearing it up, but a major improvement in their sleep apnea with sleeping on their side or their stomach. Now, in the postoperative period, that can be pretty difficult. And so we do things like elevation of the head of bed, although the sleep number bed advertisements might suggest that that clears things up in everybody, and certainly not the case, but it certainly can make a difference to elevate the head of bed, and it's something that we use for a variety of reasons in the postoperative period. And then for people, they're not hopefully drinking alcohol in the hospital, but for as far as preoperative, just in general life, avoiding alcohol or other sedatives, especially within about 3 hours of bedtime, can decrease the effect of alcohol or eliminate the effect of alcohol on their snoring or obstructive sleep apnea, because it's pretty common that people say, I don't really snore unless I've had something to drink later in the night. So positive airway pressure therapy, shown there as PAP. This is what it generally looks like. This is just one company's system. It's effectively an air blower that sits on the nightstand and blows air through a tubing to a mask. Here's one that goes over the nose, but they can go over the nose and the mouth together or tuck inside the nostrils a little bit. And this was commonly used for patients in the postoperative period. But we really don't use that very much because the generation of aerosols during the pandemic makes this not ideal. So in fact, I have some patients who say, I'm wearing CPAP a little bit, and I say, I used to say, bring it to the hospital, but now I say, just leave it at home, because we're not going to really want to put you on it unless there are, urgent or emergent situations. But that's certainly the mainstay of treatment, and where nursing, really all of the entire healthcare provider team, very important, education, all those things that Grace mentioned, and talking with patients about, here's how it works, here's why you've got to wear it all night, every night, here's why it's so helpful, here's what things look like in terms of your oxygenation normalizing, and hopefully here's what it looks like in terms of you feeling better. And so a lot of effort goes into that. I order positive airway pressure therapy all the time. I think it's fantastic. I have friends, family members actually, that use it as well. But it's something that can be difficult for patients to wear, which is when it comes time to think about other surgery and special mouthpieces called oral appliances. So in adults, the common role of obstructive sleep apnea surgery are those who do not have good adherence or benefit from positive airway pressure therapy. There are different studies out there, but the most common estimate is that that's about 30% of all patients. So it's pretty common. And so in addition to those behavioral measures like weight loss, don't sleep on your back, things like that, the options are doing nothing else, and often that's actually okay. But that's when we start thinking about surgery or these special mouthpieces. And the goal is that we want to improve the signs and symptoms of sleep apnea, so get people feeling better and sleeping better. And of course, we want to improve the number of times per hour they have blockage and breathing. Interestingly, the evidence is much stronger. Untreated, especially severe obstructive sleep apnea, has adverse consequences, that it's bad. The treatment of it is not as crystal clear in terms of the help that it offers. I won't dive into all that, but honestly, prevention is worth an ounce of cure. So we really want to prevent people from getting there to the point of having obstructive sleep apnea. But potentially surgery, just like positive airway pressure therapy, may be helpful, although we don't totally know that just yet. But with surgery, the goal is, of course, to eliminate obstructive sleep apnea, and there are many things that are available. So how do we choose them? Well, there's a lot of information, a lot of studies out there showing that effective surgery must be directed to the site or the sites of obstruction. And I told you a little bit about how there's these different areas of the breathing pathway in the nose, the palate and tonsil area, and then this is just from my website, but what we call the tongue region, but it's the tongue, and behind this structure called the epiglottis that many of you obviously are familiar with. And so we want to figure out what's going on to then take this now wide array of treatments, surgical procedures that are available to treat either the palate, and here are all these different palate procedures, to treat the area behind the tongue, either treating the tongue directly or things like the epiglottis you see down here. There's a newer treatment, it's actually not that new anymore, approved in 2014, but it's a nerve stimulator treatment, stimulate the hypoglossal nerve, and we'll talk about that. And there's also jaw surgery, so moving the upper and the lower jaw, the maxilla and the mandible forward to open up space for breathing. So how do we choose these? Well, we start in the office with a fiber optic examination. No surprise to anybody. We have these telescopes that we can look in the breathing pathway, and that's done while people are awake. But you know what? People are having obstructive sleep apnea when they're sleeping. And so I joke with patients that I could, do a little bit more, but in terms of coming to their home and doing a fiber optic telescope exam, but we can also do this in the operating room under sedation. So here's what an awake exam looks like. Hopefully I'll just skip forward so we don't show someone's name. So we look in the mouth, and hopefully I don't have this disoriented view. I turn the camera. So that's what we look in the mouth and things we see when we look in the mouth, just basic stuff. Okay, here we are in the nose. So the nasal septum, that divider separating one side of the nose from the other. Got to clean the telescope here. Get the focus right. So we're going in the left nostril. So the septum is on this side of the screen. These are normal structures called the turbinates. And so we've applied some medication to shrink down the turbinates so that we can have more space for the telescope. But now we're looking to the back of the nose. Here's the adenoid. I guess I didn't like we're looking on both sides, I guess. So the septum, which is pushed over to this right side, it's more narrow on this side. And these are things that we do in the office all the time. So we're going to look through the nose. And so we're going to the back of the nose here. And what we're doing now is we're looking down the throat. So the orientation, this is the back of the throat, sort of on the top of the screen. Here is the back of the soft palate. We're not used to looking at this, but we're looking down the throat. And so this is what things look like when they're awake. Here's space or breathing behind the soft palate. And then here's the back of the tongue right here, the epiglottis here, and here's the larynx or voice box. Now, of course, people are awake in the office, so they're basically, the space of breathing should be open. But the problem is when they're asleep, that's when things totally change. And so I alluded to this before, but there's a technique that we've renamed drug-induced sleep endoscopy, which was first described almost 30 years ago in the United Kingdom. And basically, right here in the middle, you see that it's fiber optic examinations. So the same kind of thing, but it's with patients who are sedated in the operating room. The goal of the study is not to diagnose obstructive sleep apnea, but to reproduce those patterns that we see on this sleep study that actually diagnoses people in natural sleep. So I've been pretty involved with this my whole career. So we renamed it with a couple of European colleagues. We gave it this name. And we also developed a way to characterize the findings of what we see. And there's this acronym called VOTE, stands for V for velum or soft palate, O for oropharyngeal lateral walls, and I'll show you what these all mean, T for tongue, and E for the epiglottis. And the idea was that people weren't speaking the same language. And so developing a common way of describing things allowed us to standardize, compare findings and results across different centers. So here's usually the most enjoyable part of my talk, the videos of sedation and people snoring. So V is for velum or palate. The orientation is going to be the same. The top of the screen here is the back of the throat. Here's a soft palate, and there's the uvula, the thing that hangs down like a punching bag in the back of the throat. Here's someone with the things vibrating. They have what we call palatal flutter snoring, but their space for breathing is actually relatively open compared to a lot of patients. Here's someone that has everything collapsing, caving in all directions. And so not a lot of space for breathing there once things narrow. And that's a little bit of a problem. Here's someone that just had really big tonsils. And you can barely see the edge of it because you're not looking through the mouth. You see the edge of them right there and right there. And really the airway never opens up. And so they did great with just taking out those tonsils, but it's sort of humorous because the uvula says hello here. Anyway, maybe you don't think this is funny, but it's funny to ear, nose, and throat doctors, and certainly to me. So that's a really common thing. We all know about the soft palate and fluttering around, but there can be other things going on. So O stands for oropharyngeal lateral walls, the sides of the throat. And what you see is the tongue is here, the epiglottis is here, and they're not falling backwards. So they're not falling towards the top of the screen. What's happening is just the sides of the throat are caving in. And it turns out that's pretty different and a pretty important distinction between different things that might be going on in different patients, because we don't actually have surgeries to treat this very well. And here's another patient. Again, the tongue is not really moving much. The epiglottis is not really moving. It's just the sides of the throat that are caving in. So T stands for tongue. Tongue, that's a normal back of the tongue base. The view is blocked a little by the soft palate right here, so you have to move the telescope around, so I moved it down lower in the throat. And what you see is the tongue is really just falling back to block breathing, and if that's what's happening during sleep, it explains why for a long time surgeons, we just had surgery for the soft palate, we didn't have procedures to treat the tongue. And so results weren't that great for many patients. And sometimes these things obviously can happen in combination. So here the tongue is falling back and pushing this epiglottis against the back of the throat. And this actually produces a pretty funny snoring sound. But anyway, the point is that these things can happen in combination. The epiglottis can be pushed back by the tongue. I love watching these with couples because I'll ask the bed partner, does it sound familiar? And of course, they'll say, that's the sound, but it's usually a lot louder at home. So it's I get a kick out of that. But E is for epiglottis. And here we see the epiglottis right here is falling back on its own. So the tongue is actually out of the field of view and really not falling back to push it, but it's really, the epiglottis can be falling back by itself. It's not super common, but it definitely occurs. And that's why we have some treatments that can target this. Okay, so here are some of the procedures that we have available. For a long time, this was the main surgery that was done for obstructive sleep apnea called uvulopalatopharyngoplasty, or UPPP. Basically, it would involve taking out tonsils if patients still have them, removing the uvula and a part of the soft palate to make the patient on the left side look much more on the right side. And what you care about, of course, is not what it looks like when someone opens their mouth, but really what's happening behind the soft palate, because now you've removed some tissue. So hopefully you have more space for breathing behind that soft palate so that you don't get the obstructive sleep apnea. And that was very helpful in some patients, but not as helpful as we might have liked. So in fact, there are a couple of procedures that were developed that are based not just on cutting things out, but moving things around. And I won't bore you with all the details, but this is called the expansion sphincter pharyngoplasty. All these things have awful names. But anyway, there's different techniques or different names for sort of variations of this technique, but it involves taking out tonsils. And then basically there's a muscle behind the tonsils. It's called the palatopharyngeus. And basically you sort of have to cut it and then move it forward. It's sort of shown here, but effectively what you're doing is leaving it attached on the soft palate and taking this muscle and pulling it to the side, forward, and up a little bit. And basically you're almost anchoring the soft palate a little bit more forward. And what that does is, because the muscles relax during sleep, is that when we're asleep, because things are held forward a little bit, it's harder for this soft palate to fall back and block off breathing. And it turns out it actually works better than the older approach of just cutting things out. I won't go into all the details, but there's another technique called lateral pharyngoplasty. And these things are also based on moving things around. Here's a different thing where technique where you cut this muscle a little bit and you basically move the muscles to the sides of the throat, making the throat a little wider here. And as you might imagine, of course, these could be quite painful, and we'll talk all about that. But this is another one that works a little bit better, it seems, than just cutting out tissue. So those are the most common things that I do for treating the soft palate, things that you might see in the operative reports or things like that on the floor when patients come in to get their care. And tonsillectomy, by the way, in adults, it's one of the most painful things that we do. It's why we're very aggressive about treating pain, but also want to be careful, and we'll talk about that. I mentioned before how the tongue can play a major role in obstructive sleep apnea. The genioglossus advancement procedure addresses the tongue by taking advantage of the fact that the major tongue muscle, called the genioglossus muscle, attaches on the inner aspect of the lower jaw or mandible, roughly over a rectangular area. And so we actually cut a little rectangle out of the lower jaw and pull a little piece of bone forward, shown here, put a little titanium screw to hold it in place. And the idea is that when our muscles relax, the tongue, which is basically a big muscle with some fat in it, it's less able to fall back and block breathing here because it's pulled forward a little bit. Another tongue treatment is called tongue radiofrequency. Radiofrequency is used in many areas of the body, used for heart, cardiac arrhythmias, can be used to treat the prostate glands and in various oncology applications. We use it as otolaryngologists in different parts of the breathing pathway, the upper airway. But the basic idea behind it is that you give heat energy to create injury of the tissues that then turns into fibrosis or scarring. And what you see here is treatment of the back of the tongue. Here's the front of the tongue. I also treat the sides of the tongue. You won't actually see too many of these folks because it's often an outpatient procedure. There's these various technologies, but I treat these different areas of the tongue, and effectively you tighten up the tongue. You create a little scarring in the tongue, not the entire tongue, of course, but you create tightening of the tongue so that while muscles relax during sleep, scar tissue does not relax. So by scarring the tongue down in certain key areas, the tongue is less able to fall back and block off your breathing here behind the tongue. Hyoid suspension is another procedure, or actually you're doing one on tomorrow. But basically the idea is that in the humans, this bone called the hyoid bone can move around, whereas a lot of animals it's fixed in position. And the idea is that there are a lot of soft tissue that attach to the hyoid, including an attachment to the epiglottis, and pulling this bone forward and putting a couple stitches here against the thyroid cartilage or the Adam's apple, you hold it forward and pull everything that's attached to it and basically prevent it from falling back. So it's one of the things that can be done for treating the epiglottis. I won't bore you with all the different technique aspects of things, but that's the procedure that I perform for hyoid suspension. There are other more involved procedures. I don't really do these as often anymore. Midline glossectomy, so cutting out part of the tongue, sort of like a cancer surgery, initially was described for sleep apnea with a carbon dioxide laser or regular electrocautery, but it was pretty morbid. A lot of heat, a lot of swelling, a lot of pain, a lot of trouble swallowing, a lot of never leaving the hospital. And so basically people sort of abandoned that, but actually there's a newer technology that's been around for a long time, but these techniques that use a lower temperature kind of heating to really remove tissue. You can actually remove part of the tongue in the middle. You're staying away from the major blood vessels and nerves on the sides of the tongue on each side. But basically you can remove part in the middle, and then you can actually go more superficial on the sides, protecting with what's shown here is a metal retractor, protecting the blood vessels and the major blood vessels and nerves, basically removing a little bit of tongue tissue so that you make it, these big tongues that we commonly see in sleep apnea patients fit more easily within someone's mouth naturally. Or I guess maybe not so naturally, but with the assistance of surgery. So this is one of this treatment I mentioned earlier, the hypoglossal nerve stimulation. This is the brand name for the one technology that's FDA approved in the United States. So this is Inspire is the company that makes it. It's a fully implanted system that has three components shown here on the right. The first part, the pulse generator, is effectively a pacemaker. And it sits on the upper chest, shown here on the drawing, underneath the skin. So again, everything's fully implanted. And there are two wires that are connected to it. The sensing lead shown here basically comes down here and it's between the intercostal muscles to sense breathing patterns. And there's a stimulation lead tunneled underneath the skin to the neck to place on a portion of the hypoglossal nerve. And the idea is that when this is turned on with your remote control that you have to hold over the chest and turn it on at nighttime and press pause button if you get up to go to the bathroom at night or something like that. But while it's on, when you're sleeping, when the sensing lead senses when you're breathing in, so that this generator knows to send a signal to the hypoglossal nerve to move the tongue forward. And again, it opens up the space for breathing. This is done, and patients do stay overnight, so you may have already seen some of these patients, but basically it's something where people stay overnight for observation purposes. It's an easier recovery period than a lot of the other procedures I do, and it can work well, but it's actually importantly, it's turned off when it's put in. So people are gonna come after getting this implanted, they're actually not going to have their sleep apnea treated. It's something we need to keep in mind for a lot of patients, but especially these, that we need to be very careful because they've had anesthesia and need some pain medicine, and they're still going to have their sleep apnea just like they had before surgery. So let's talk about how we minimize some of these risks. Well, first, let's talk about what the risks are and why we expect, building on what Grace mentioned, why we expect there to be some risks of surgery. Well, first is that patients have an abnormal airway. We know that when they are asleep naturally, they have repeated blockage in breathing. So we know that certainly when they're asleep, their airway is more compromised. And adding to that, they're getting anesthesia. And so in the operating room, we're very worried during induction, so start of anesthesia, as well as wake up. But they still have these medications in their system. And so, during the recovery period, we have to be mindful of the fact that those anesthetics they received during surgery can suppress their ability to naturally wake themselves up, which they did at home. When they get blockage breathing, they would naturally wake themselves up. But we're suppressing that with the anesthetics and then, of course, with pain control, the narcotics. And so we need to be careful about that. I don't want to give everybody, thinking that everyone with sleep apnea is a disaster, going to happen for sure, because I'll show you on the next slide, the risks are not so high of serious complications, but they're important to keep in mind. We take another number of steps to minimize those risks from an airway standpoint. And then often there could be cardiovascular comorbidities, and often these patients can have pulmonary comorbidities. And so we need to be mindful of treating, of course, the entire patient, and certainly not just from a sleep apnea surgery perspective, but in other kinds of surgeries where patients with sleep apnea are having these other procedures. So what really are the risks? So I alluded to this before. I think for a long time in the otolaryngology and sleep surgery world, we had a couple of studies that were from single centers. But I was involved in looking at data basically from the entire US at the Veterans Affairs medical centers, publishing these papers a long time ago now, but 2004, 2007, looking at how common were complications from sleep apnea surgery. And what we showed was that the risk overall of serious complications like stroke, heart attack, prolonged intubation, things that were meaningful, not just self-limited drops in oxygen saturation in the recovery room. That's not really a meaningful complication, but things that are pretty serious, between 1% and 2%, which is reasonable, but actually a little lower than some of the initial studies had suggested. Because what would happen, of course, is someone would get a terrible event, and then they would say, "Oh my goodness, how common are these things happening?" And they would have like 1 or 2 events, and they would do like 40 surgeries, and then they would say that comes out to about 5% risk, but it's not really quite that high. But it's still high and very important. It turns out that we also looked at what were the risk factors. So who was more likely to get these serious complications? And like any surgery, it was those with significant medical comorbidities. So I see patients all the time, they send over to say, they gotta have surgery because they've got unstable angina, they've got bad sleep apnea, they're not wearing their CPAP. And I basically will often say, you know what, unstable angina is such a significant medical problem. I don't think that patients are so safe to go through the stress of surgery. We need to figure out if we can do something small to maybe make them more comfortable with CPAP or figure things out a little bit better before having them undergo major surgeries. But anyway, importantly, the risk of mortality was about 0.2%, so 1 in 500. So it was important, but the risk of mortality within 30 days of surgery was not especially high. Importantly, it's not just sleep apnea surgery that these patients are undergoing. Like I mentioned, they're undergoing other surgeries, and the literature is not as detailed as we might like. Grace presented some work from Stuart Kwan and his group. There's a Canadian anesthesiologist who's done a lot of work in this area. But the best study looking at specific kinds of procedures is actually in the orthopedics world, looking at knee or hip replacement. And so the sleep apnea patients had higher risks of airway and cardiovascular complications because, and some of the complications weren't quite as serious as the ones above. So there are different definitions of complications, but these were felt to be meaningful complications. And importantly, CPAP use, back when we were using CPAP in the hospital, patients brought their CPAP and used it, that lowered the risk. So the ones that had sleep apnea, they lowered their risk to 9%, which was the same as the group that didn't have sleep apnea, whereas those who had sleep apnea didn't use CPAP after surgery, they basically had a much even higher risk of having these complications. So how do we actually do this in our postoperative management? And here I'm going to be talking about primarily in sleep apnea surgery, but things that are probably applicable. So we go back to the ABCs, of course, airway, breathing, circulation, and of course, pain control is an important part of things. So from an airway and breathing perspective, we have everyone on humidified face tent, basically giving them oxygen as needed to maintain saturation. I typically like to use a 92% threshold for administration of oxygen. Patients typically do not need to go home. We accept some desaturations, but soon after surgery, especially if they've got anesthesia in their system, they're taking narcotics, we want to make sure they're not desaturating too low. And so we give them oxygen, of course, if they need it, but we do make sure that they're safe without oxygen, that they only have relatively low levels of desaturation after surgery off oxygen. We're very liberal in the use of Decadron. Of course, Decadron is so important, treating many things, including the COVID infection when it's serious, but we use Decadron liberally to minimize swelling because that's our enemy when it comes to keeping an open airway. If we do nasal surgery, we use Afrin, of course, as needed to keep the nose open. The nose is not usually the main cause of sleep apnea, but it's something that can be important if we're doing throat surgery to at least have the nose open. CPAP is shown there in italics. Patients who still have it, we used to have them wearing it every night, and we do have them still wearing it when they go home, but that's not something that we typically use in the hospital. There's some limited evidence that CPAP can decrease swelling, and certainly you can maintain an airway by having this air blower keep things open. We actually keep low levels of fluid. We don't want to be flooding patients and having them develop edema related to fluid overload, not only in their lungs, but really in their soft tissues of the head and neck. And then with certain procedures, the one critical one being the genioglossus advancement procedure, where the surgery is done right here on the chin, we actually have holding ice over the chin. And what we have gone to is putting ice in the mouth for any kind of surgery, because it's like if you twist your ankle, you put ice in there. And thank you all for all of your work. It's really an important benefit for patients in terms of cutting down swelling and decreasing narcotic use. And we'll get to that a little bit later. From a circulation perspective, there's some nuances for different procedures. For the genioglossus advancement procedure that cuts the mandible, can't really sew bone closed. So in fact, we want to really control pressure aggressively using thresholds of 140 systolic and 90 diastolic to really use labetalol, hydralazine to really keep that blood pressure low, because we don't want bleeding in this area, because what that can do is cause a hematoma in the floor of mouth, so underneath the tongue, pushing the tongue backwards. And of course, we want to minimize bleeding and the associated edema that comes with high blood pressure. So that's why we have people on their antihypertensives. And then we want to get people walking. Obviously, minimize DVTs and other kinds of risks, help with their lungs and minimize atelectasis, all that. So for pain control, both prior to surgery, at the time of surgery in the preoperative area, and then postoperatively, I've gone to using celecoxib or Celebrex. And I actually will push the envelope a little bit. I think anti-inflammatories, of course, are important. We use Decadron, et cetera, but I think those are very helpful, and they do not seem, at least in vitro and test tube in the labs, they don't seem to increase the risk of bleeding, and we like to keep it like that. The ERAS protocol, and Mark, of course, head and neck surgeon, they use ERAS protocol, and they use gabapentin or Neurontin. I think, and we've talked about this at our departmental events, I think the evidence in supporting gabapentin is very flimsy, and I don't think it's actually the greatest medicine to be using for anyone, but especially not in the sleep apneics. I really think it's a terrible idea for sleep apneics, because it causes sedation without giving pain relief in the immediate postoperative period in my patients, because my patients experience pain that's inflammatory. Gabapentin is a neuropathic kind of pain treatment, and so I think it's not something to use. And that's why we do not order. We do not use the ERAS protocol that's used for head and neck patients. And we think it's like this race in the morning to get in to see my patients, because everyone thinks otolaryngology, give them gabapentin. But in fact, that's not what I like for my patients. And so we have to sort of stand there at the bedside and make sure we find the anesthesia team and make sure they're not going to be getting that. So I mentioned ice chips in the mouth, super helpful in cutting down swelling, but also with pain control. We're aggressive with use of pain control. We used to give a lot of IVs and then switch to oral, but actually we really start with the oral only now. And so we'll give IV if needed. We do not use PCA. There's an easy risk of overdosing, and there's lots of examples of sleep apneics, especially with having a basal rate. But even when we used to have visitors, family members that would come visit, they would hit the PCA button, and that's just a disaster for these sleep apnea patients, a disaster waiting to happen. So pain control is important. I mentioned earlier that it minimizes elevated blood pressure and associated risks of bleeding, as well as edema. And really, these patients only stay in the hospital usually just 1 day, sometimes 2 days, but we want to aggressively control their pain, get them on the regimen that they're going to get at home. So that's why we really have gone to just starting out with oral medications only, but get them on the regimen they're going to have at home to be able to discharge them safely with their ability to maintain adequate oral intake. So in conclusion, obstructive sleep apnea is common and increasing in a world facing the pandemic of obesity, the other pandemic going on. But the consequences of sleep apnea include snoring, health effects, and sleep disruption. We have this array of treatment options, and the key really is getting effective treatment. So Grace alluded to many outstanding things that can be very helpful, but often when we're seeing them for certainly sleep apnea surgery, they haven't had great results with these other options. And even for those, and then for the sleep apnea surgery patients, as well as the other patients going other kinds of surgery, it's important that you talk with them about effective treatment. And of course, most of this should be done prior to coming to the hospital on an outpatient basis. I mean, your nurses are amazing. You have so many things you have to do to expect you to solve everyone's sleep apnea problems when they're, not able to get this addressed adequately prior to coming to the hospital is asking a lot. But certainly checking in and seeing if someone, they know that they can, for example, go back to using CPAP and some procedures that we do, not just in my world, but some of the nasal surgery, some of the skull-based surgery. We actually have them stop CPAP for a little while just to prevent other kinds of complications. So certainly checking with them about whether they can resume use of treatment of other treatments, of sleep apnea once they go home. It's an important discussion to have. So in short, nursing care and awareness of nurses and the whole healthcare providing team is really the key to minimizing the risk of surgery of any kind in sleep apnea patients. I've got it.
Thank you guys for your talks. I just want to open it up real quick if anyone has any questions for Dr. Kezirian or Grace, and then I have a couple afterwards. So Dr. Kezirian, maybe get things started. I had a question. So if we have a patient of yours who's admitted after OSA surgery and they're falling asleep and they're desatting a little bit, how much desat is okay? Should we give oxygen? Should we reposition? Should we leave it alone? Should we restart their CPAP? How should we troubleshoot a patient with desats while sleeping post-op?
Sure, great question. And of course, everyone can call me Eric, please. So the first and foremost, I think that right after surgery, because of anesthetics and because they're just figuring out, what their narcotic needs are going to be, that we obviously would want to give them oxygen. But we are going to understand that this is what happens to them every night at home, but we're especially challenging their body's ability to maintain normal oxygen saturations because of everything that we've done to them, not just with the surgery, but all the medications that have been involved in their care. So the first thing, of course, is to give them oxygen. Elevating head of bed is something that is very important and that we do as a standard thing to cut down on swelling, but it can also be somewhat helpful for a variety of reasons. Of course, waking them up and encouraging take deep breaths. And in fact, I didn't put it because there's so many things going on, but we often use instead spirometry, just like many other patients in the hospital, to maintain adequate lung volumes and prevent atelectasis. In terms of what's acceptable for someone going home, I do like to see patients, of course, off oxygen before they would go home, as part of why we actually ask the nurses to record oxygen saturations during sleep, not just when they come in for their vital signs check. It's why we have continuous oximetry and telemetry for these patients, is because we want to know what's happening naturally to them when they're sleeping and recording that so we have a sense of it, how much their oxygen saturations are dropping. If someone's dropping to 88%, that's actually can be well within the range of normal in anyone. But basically, if they're dropping to 75%, that's probably not as ideal. So we want to get a sense of that, figure out how it compares to what they were having in natural sleep, and make some decisions about what we might do. A lot of factors go into whether we have them safe for discharge. For example, if someone's using CPAP a reasonable amount, but just not having full relief of symptoms, we actually might accept a little bit more desaturation, because when they go home, they're going to wear their CPAP. And it's something that, as long as it's not dangerously low, I probably still don't love 75%, but it's something that you say you're going to go home, and while you can't really wear CPAP in the hospital, you're going to go home and wear CPAP. So I'm not as worried about you as I would be about someone who was completely unable to wear CPAP at all. So there's a number of factors that go into it, but if just, use the basic interventions that you would use in anyone, of course, starting with oxygen. And of course, we do different things like maybe watch them an extra day, all these kinds of things that go into the equation of the other kinds of healthcare, interventions that we might use.
Thank you. Anyone else have any questions?
I had a question.
Go ahead. Oh, Dr. Kezirian, when you implant the nerve stimulator, from a nursing perspective, do we treat the patient as if they got a pacemaker, where they're not able to, or they're not allowed to raise their arms above their shoulder and they're wearing a sling?
Yes, so that's in the one of the instructions for following surgery, and it's something that for actually like 3 to 4 weeks, we have them not elevating their arm above the level of their shoulder. So that's exactly right. So the device is off for those first 4 weeks, and they have to be somewhat limited in physical activity, especially it's typically on the right side, pacemakers on the left, but basically not raising that arm above the level of their shoulder. So that's exactly correct.
Thank you. And then Dr. Kezirian, one more question. We've taken care of your patients quite often, but when do you decide it's time to move on from Norco to like oxycodone? Because we call you directly on your cell phone. So I just kind of want to know, when is it time, like how many doses have they tried Norco and it's ineffective and not controlling their pain, and it's time to maybe possibly move on to a little stronger medication?
Right. So pretty early, actually. So if someone's not so I guess the two things that come into play are, number one, how much does, two Norco tablets, how much does that increase their pain severity? So if they go from 7 to 6 with 2 pills of Norco, right away we're moving to oxycodone. If they go from 7 to 2 for 3 hours, and by 3 hours they're coming back up, we might write it out for another dose. So give them a single dose of IV pain medication, but to tide them over, and then try it again. But we're not shy about moving to oxycodone. But that's what it's important to get a sense of those things to see whether it's providing any benefit at all, and then how long that benefit might be lasting.
Thank you.
Sure.
So I had one quick question for our nursing and one quick question for Eric. Maybe for Eric first. If we have a patient who's bleeding after surgery, how much bleeding is normal? When should we call you, and what should we do until you come if it's severe?
So that's a great question, and it's complicated because it depends a lot on the kind of surgery. So if someone has having nasal surgery, we expect there to be some nasal bleeding. Actually, it can last for a couple of days, but it shouldn't be obviously pouring out. But if someone has only throat surgery, they really shouldn't have bleeding. Now, the one exception is this highway suspension procedure, where we actually put a little Penrose drain in the neck. We have this big gauze dressing that's just wrapped around the neck. And we want the drainage to come out. So we don't use the Jackson Pratt drains and other kinds of drains that are used in head and neck patients, but we actually wanted to come onto the dressing. And so we'll, understandably, because it's not something that we do very often, we'll get a call to say, oh my gosh, there's blood on the dressing, and can I change the dressing? And in fact, we don't want that to happen. And it's usually in the instructions, in the nursing instructions, but we just want, basically, you can put more gauze on it. We take the whole thing out usually the day after surgery, but there are some bloody drains will show up in the dressing, and that's expected. So what I'd say is, feel free to call for any bleeding, but if they've had nasal surgery, we would expect that. And so don't be alarmed. But of course, if they're having bleeding from their tonsillectomy part of things, their soft palate surgery, that's something we want to know about right away if it's more than a teaspoon of blood.
And then my question for the nurses is, maybe it's similar for sleep apnea patients, but for example, robotic cancer patients, they constantly feel like there's phlegm in their throat, even though maybe it's just related to swelling, and they do a lot of throat clearing and coughing and stuff like that, which can aggravate the tissues. Does anyone have any tips that they found that they can coach patients to find ways of not doing that?
Dr. Swanson, I give them a whole pitcher of ice, and like it kind of like dilutes that thickness, the viscosity of their saliva. It gives them relief. And then Dr. Kezirian loves seeing ice chips at the bedside because they're just going for it. So, and with our other robotic surgery patients, they enjoy it. I mean, it also like gives them a sense of oral gratification.
Yeah, that's a good idea. I always tell patients it's like an ice pack for the throat, so it helps. I think the key is it's a habitual thing. So if, whenever you feel the need to clear your throat, stick an ice chip in. That's a good idea.
And the other two things I would add. Number one is our typical thing. It starts in the recovery room sometimes is give people lozenges, and because I think there's a little bit of a flexibility to allow nurses to do that. But in fact, those can actually be very irritating the tissues. And while they're great for the average patient, for a lot of our patients that have these raw areas in their throat, it actually can really irritate things. So it's something that it's hard to know. But what I would say is don't hesitate to call us. And before that we run out of time, I just want to thank you all. I think I have patients all the time that come in and basically will say that we had an incredible experience here. They've either never been to Keck before, or they were so scared about everything. And so first of all, reassuring people that are throat clearing, but just in general, patients get fantastic care here at Keck, and you're such a huge part of that. So I want to thank you. That's why I was so excited that we have this series going on, and volunteered right away with Mark.
Hi, Dr. Swanson, or for either one, this is Sandy. I've had experiences where the patients have complained of pain and nothing is helping them. And sometimes I'll ask the doctors, to order Decadron. Is that something that would be recommended, or why would you go against ordering Decadron if you don't order it?
I typically do. I use it for 24 hours, 8 milligrams every 8 hours for 3 doses. Sometimes people are having a tough time and they're staying a second night. We'll continue that a little bit. We don't want to be reckless, but I think I use Decadron pretty routinely, actually, unless someone's got diabetes or significant hypertension that just really exacerbated by this.
Mm-hmm. Because I see on other
Sorry.
robotic surgeries. I'm sorry, go ahead. Sorry.
Oh, no, I was going to say I have a similar approach with Dr. Kezirian. I usually do 24 hours of Decadron, unless a patient has a trach. If a patient has a trach, I usually avoid Decadron because it can impede healing. And the Decadron I kind of think of as helping with protecting the airway. And with a trach, they already have a safe airway, so I want to try and maximize how they heal. That's what I didn't mean to interrupt you, Sandy. What were you going to say?
No, that was it. No, just because we had a patient who had I think it was a partial glossectomy, and we thought he would be going home the next day, but I think he had other comorbidities or some anxiety that probably was not helping him. And I think it was by the 3rd day is when we decided to add Decadron to his regimen. And after a dose, I don't know if it was just coincidental or maybe it did help, but I thought maybe we could have used that a little bit sooner. Does that make sense?
Yeah, that's a good thought. I think it's worth thinking about in a lot of our patients.
Uh-huh. All right. Well, thank you.
Thank you for joining our lecture series. We're going to have more of these in the new year. We'll send out a calendar so you can see up through, I believe, June or even further.
All right. Thank you, everybody. Thank you, Dr. Kezirian, Grace, and Tamara. We'll see you guys for the next one.
See you soon.
Thank
And
you.
again, if you haven't entered your
Thank
name
you.
in, please do so in the chat so you can get your CEU credits.
Thank you, Dr. Kezirian.
Thank you.
Thank you.